My name is Mary Dement. I am a PGY3 at Advocate Lutheran General Hospital in internal medicine. I am presenting a case of newly diagnosed autoimmune hepatitis with hepatocellular carcinoma. To begin, we'll introduce autoimmune hepatitis and hepatocellular carcinoma. The clinical presentation of autoimmune hepatitis is widely variable. It may present as acute or chronic hepatitis, or less commonly as cirrhosis. Although hepatocellular carcinoma, or HCC, is a known complication of cirrhosis, the prevalence is low, at 1 to 9% of patients diagnosed with autoimmune hepatitis-related cirrhosis. The incidence of undiagnosed AIH presenting with HCC is not well documented. In this report, we present a case of autoimmune hepatitis presenting as hepatocellular carcinoma. Our case begins with a 70-year-old male who presented to the hospital with right upper quadrant discomfort. He rarely ingested alcohol and denied IV drug use. His physical exam was notable for right upper quadrant tenderness and negative for stigmata of chronic liver disease. A CT and MRI demonstrated a mildly nodular hepatic surface contour and a 7.7 centimeter mass centered in the right hepatic lobe, as well as a 3.7 centimeter lateral left lobe mass and multiple small lesions scattered throughout the liver. The spleen was mildly enlarged with several tiny foci within the spleen, which were too small to characterize. These findings are demonstrated in Figure 1. They were strongly suggestive of hepatocellular carcinoma. A markedly elevated alpha-fetoprotein, or AFP, confirmed hepatocellular carcinoma. Other extensive liver serology was notable for an elevated ANA and SMA titers, as well as an IgG level at the upper limit of normal. These laboratory values are demonstrated in Table 1. The patient was diagnosed with autoimmune hepatitis complicated by compensated cirrhosis and hepatocellular carcinoma. He was ineligible for transplant based on Milan criteria and was therefore referred for liver-directed therapy. Our discussion of hepatocellular carcinoma and autoimmune hepatitis. Hepatocellular carcinoma was previously thought to be an extremely rare complication of autoimmune hepatitis, even in the setting of cirrhosis. However, more recent evidence suggests that it may be more common than previously thought. Diagnostic criteria for autoimmune hepatitis includes laboratory and histologic findings, with the latter being required for a definitive diagnosis. Although liver biopsy was not obtained due to concern of seeding tumor cells, our patient demonstrated findings suggestive of autoimmune hepatitis. These findings included a positive anti-nuclear antibody and smooth muscle antibody, as well as IgG levels at the upper limit of normal. Moreover, other causes of chronic liver disease were excluded, including non-alcoholic fatty liver disease. A negative anti-mitochondrial antibody and anti-double-stranded DNA make an overlap syndrome of autoimmune hepatitis and primary biliary cholangitis unlikely, which increases the likelihood that our patient had a proper diagnosis of autoimmune hepatitis. In conclusion, our case not only emphasizes hepatocellular carcinoma as a potential complication of autoimmune hepatitis-related cirrhosis, but it also represents a unique case of AIH presenting with hepatocellular carcinoma.